Great, welcome everybody. We're glad to have you. I hope you've been enjoying the conference so far. As Jesus said, this session is on unequal cities, structural racism, and the death gap in America's largest cities. I'm Maureen Benjamins. I'm an epidemiologist and senior research fellow here at SUHI. I've been here for 16 of our 20 years. The organization and the people and the mission are very close to my heart. I'll be joined today by Nausea Syed, who is also an epidemiologist at SUHI, along with Fernando De Mayo, who is the Director of Data and Research at AMA Center for Health Equity, and also a professor of sociology at DePaul University. Fernando started working with us on this when he was a SUHI faculty research fellow back in 2019. And then finally, we have Nick Prashant, who's the Director of Epidemiology at the Chicago Department of Public Health. We're really excited to have him here with us today. CDPH has been a great partner to SUHI for all of our 20 years. Before we start, I'd like to acknowledge all the people that have contributed to this line of research over the years. In particular, Abigail Silva, who is a co-author and a fellow epidemiologist on all the data that we'll be presenting today. As we'll talk about, this line of work was developed by Steve Whitman, and Bijou Hunt led a lot of the early studies on breast cancer. You'll see other fellow epidemiologists and researchers that help with other studies in this line of work. In addition, we have a book coming out with the same title as the session. It's coming out this summer, and I wanted to acknowledge all the co-authors who contributed to chapters in our book, as well as helped us in different ways by reviewing, commenting, providing data visualizations, and other help. And then finally, I'd like to acknowledge our editor, Robin Coleman at Johns Hopkins Press, Julie Morita, who was kind enough to write the introduction, and Daniel Dawes, who edits the series Health Equity in America. The outline of our session today looks like this because we're celebrating our history. We're going to start with a little background of how we got into this type of work. And then we will jump into the findings. I'll talk about the main mortality findings of all-cause mortality and life expectancy. And Fernando will talk about some of the city level characteristics that influence the mortality outcomes. And then finally, Nick will help us think more about how you can take this kind of data on racial inequities and move it out of just reports that sit on your shelf and into action, motivating or helping to guide action at the city level. Okay, now I'm going to turn it over to Nausea Syed.
Thank you, Maureen. Good afternoon, everyone. Our work in inequities in mortality at the city level really started with Steve Whitman. Here he's featured in Chicago Magazine, showing changes in breast cancer mortality over time for Black and white women in Chicago. Steve was really passionate about equity and naming racism as the root of health disparities. Here we can see the figure in more detail. So the pink line is Black breast cancer mortality, and the blue line is white breast cancer mortality. I'd like to call your attention to the way these two lines intersect at the beginning part of this graph. Starting in 1980, the rates for both Black and white women were almost the same, and they stayed that way for 12 to 15 years. At times the white rate was higher, and at times the Black rate was higher. But starting in the mid-90s, the white rate started to decline pretty dramatically while the Black rate stayed the same. At the time the study was published, the Black rate was almost double that of the white rate. And it's a common misconception that, at the time people would say that there were probably genetic reasons that there was a difference in mortality, but really looking at these trends over time shows that genetics are not the reason. If that were the case, we wouldn't see changes in the way that the two rates compare to each other. It's really more likely that there's a systematic reason preventing Black mortality from declining the way white mortality has. So Steve began to wonder if the same trend existed in other cities. So here he worked on a follow-up study with Bijou Hunt, a SUHI epidemiologist, and Mark Hurlbert from the Avon Breast Cancer Crusade. They compared breast cancer mortality rates among Black and white women in the US and 4 cities, New York, Los Angeles, Chicago, and Memphis. The mortality rate ratio is what's presented in this chart. So that's just calculated by dividing the Black mortality rate by the white mortality rate. So if the rates were equal between Black and white women, the rate ratio would be 1. So looking at the chart, we can see that the mortality rate ratio is greater than 1, meaning the Black rate was higher than the white rate in all of these locations and all 4 of the time periods. But the difference changed pretty dramatically over the 4 time periods. You'll notice Memphis, which is the purple line on top, changed the most dramatically. And by the end of the study, which was 2005 to 2009, the mortality rate for Black women was 2.1 times higher than that of white women in Memphis. The inequities also increased in LA, Chicago, and the US as a whole, but interestingly not in New York City. This study and the other study about breast cancer mortality attracted a lot of attention from the media, philanthropy, and local stakeholders. Here are a few snapshots of media coverage. It was featured in the New York Times, the Washington Post, and other media outlets. The media coverage and the attention that this got led to a lot of local initiatives being developed. For example, Steve Whitman and David Ansel co-founded the Metropolitan Chicago Breast Cancer Task Force. That developed citywide initiatives like quality reporting for mammography and funding for screening. There was also work in Memphis done in breast cancer based on these studies. So SUHI researchers, after seeing the positive impact of getting this data out there, began to look into other causes of death as well. So there were a number of studies on breast cancer, followed by studies on lung cancer, heart disease, homicide, diabetes. And this set of studies developed somewhat organically. We went from one cause of death to another, and we decided in the last couple of years to go back to the beginning and take a more systematic approach to studying inequities and mortality in the city level in the US. So the first study from this new line of inquiry was on all-cause mortality, and it was published recently in JAMA Network Open. Before we get into the new line of study fully, I'd like to go back over a bit of a background of racial inequities and mortality. Basically, as long as the US has been counting deaths, we have known that there are inequities in mortality between Black and white people in the US. The CDC calculates and publicizes race-specific mortality data for the nation and every state and at the county level, but this data is not consistently available for cities. The CDC doesn't calculate it, and not all cities have the resources available to do this work. It's important to study cities, though, because cities are smaller in most cases than counties, and the larger an area that you're studying, the more variation is hidden. So for example, think of many counties include a city and its surrounding suburbs, but the suburbs are often richer, whiter, and healthier than the city themselves. So the county mortality rates will appear to be lower than the city alone would have been. Cities are also key drivers of health-related changes. There are health policies created at the city level. City departments of public health can make changes to local laws and policies a lot more quickly than the state government or federal governments can. And the US is really urban. 80% of Americans live in urban areas, and minorities are even more likely than white people to live in urban areas. And findings on variations in equities can motivate, target, and inform interventions in each city differently. This data could be useful for government officials at the city level, public health professionals, health advocacy groups, funders, community-based organizations, researchers, and healthcare providers. So as we began working in this new line of inequity work, we started to think about a few pre-research questions, and eventually these were all synthesized into a book which will be out later this year that Maureen mentioned. This book is called Unequal Cities, Structural Racism and the Death Gap in America's Largest Cities. So the key research questions that we were looking to answer were, first, how does mortality vary across the biggest US cities? And then how do racial inequities and mortality vary across these cities? And third, what city level factors are associated with mortality and mortality inequities? And do these rates and inequities change over time? At this stage, we're also looking to figure out how best we can disseminate the information that we've gathered here, and how can we help cities address the issues that have been identified. So here are the cities that we included in our study. You can see here that the bubble size corresponds to the size of the population. So New York, Los Angeles, and Chicago are the 3 largest cities in the US, but really we covered quite a wide range of of the country, not just the coasts or the largest cities necessarily. Las Vegas, just a note, has been removed from the study because of questions about who counted as a Las Vegas resident in death certificates, but we didn't have any concerns about the other cities shown here. So our data comes from death records from the National Vital Statistics System, and we use American Community Survey for the population data. For our book, we covered 5-year time period of 2013 to 2017, and the papers usually have 10-year time periods so that we could assess change over time as well. The measures of mortality that we'll be discussing today are life expectancy and all-cause mortality. So life expectancy, most people are familiar with. It just tells you how long you would expect a baby born today to survive based on existing mortality trends. All-cause mortality is the number of deaths out of every 100,000 people. In our book and in our papers, we've also looked into premature mortality, which is the number of deaths under age 75, and cause-specific mortality, looking specifically at the top 10 causes of death, as well as HIV, homicide, and opioids. The measures of inequity that we use are rate ratios, which are calculated by dividing the Black rate by the white rate, rate differences, which are calculated by subtracting the white rate from the Black rate, and excess deaths, which tell us how many more Black people died than would have if mortality rates for Black and whites were the same. And I'd like to pass the mic back to Maureen to describe some of the findings from this work.
Thanks so much, Nausea. That was a great background. I wanted to start, before we bombard you with a lot of data, I want to ground us again in the words of Steve Whitman. He said this in an interview in a magazine. We've arranged things in this country so that the darker your skin, the shorter your life will be. And I say that because it points out what Nausea mentioned, that this is not genetic, this is not preordained, it's not immutable. These are changes that are caused by structural racism, by the historical and current policies and programs and norms in our country. So I just wanted to ground us with that. Okay, so first, we're talking about life expectancy. So in the US, what this is showing is during this 5-year time period, a baby born during this time period could expect to live 78.6 years. We're really interested in the city level variation. So when I show that, this is how I will display it, with the blue coloring highlighting the best performing cities and the orange highlighting the worst performing cities. So you can see here at the top, San Francisco and San Jose have a life expectancy well above the US at 82.9 years. Follow that all the way down to the bottom where Baltimore has a life expectancy of 72.9 years. So a 10-year difference between our biggest cities. I'll leave that up 1 minute so people can find cities if they'd like. So to understand this a little better, you can look at race-specific life expectancy. So at the top, you see in the United States, a Black baby born during this time period could expect to live 74.4 years. There's some variation among the cities if you look down that first column, where Houston is the lowest, 70.2 years, up to New York City, where a Black baby could expect to live 78.7 years. If you look at the white life expectancy in the US, it's 78.4 years. And again, there's a great deal of variation among the cities. Sorry, slow animation. From 74.9 years all the way up to 85.5 years in Washington, DC. So a really long life expectancy for whites in Washington, DC, above any country in the world. And then you look at the difference. So here we're looking at the absolute difference between white and Black life expectancy. So for the US, it's 4.1 years. If you look across these cities, you see the huge variation. In Washington, DC, there's a more than a 12-year difference between white and Black life expectancy. You follow that all the way down and you see at the very bottom, El Paso, where it actually has the reverse, where the Black life expectancy is slightly greater than the white life expectancy during this period. But there's several cities down there, Columbus, Ohio, Jacksonville, Boston, that have a much smaller gap between whites and blacks than the US as a whole. So we've shown you two types of outcomes, the overall population health or overall levels of life expectancy, and then the levels of inequity. So we put them on the same chart here to help cities understand, because it's really, if you're moving forward with this data, cities would do different things if you needed to improve the overall level of health in your whole city versus if you needed to reduce the gap between blacks and whites and target efforts toward a certain community. So here we have life expectancy on the y-axis. So as you go higher, you'll see the higher levels of life expectancy with San Francisco and San Jose at the top. And as you go from left to right, you'll see greater levels of inequity. So on the far right, you see Washington, DC with that 12-year gap in life expectancy. Here you can see now by looking at quadrants like the upper left quadrant, the best performing cities. Those El Paso, Boston, New York are the best performing. So they have higher than the US life expectancy and lower than the US levels of inequity. On the other hand, in the bottom right, where you see the orange triangle and cities like our own Chicago, these are cities that are doing poorly in both. So below the US level of life expectancy and higher than average levels of inequity between blacks and whites. The quadrants that I didn't mention are interesting because they're doing well. Say look at San Francisco and LA, they're doing well. They have life expectancy above the US rate, but their inequities are huge. So they know what they need to work on. In the bottom left quadrant, you see cities like Detroit and Baltimore, where their overall levels of population health are low. Their life expectancies are down below 74 years, but their levels of inequity are not as big as seen elsewhere. Okay, this is the second outcome that I wanted to look at. This is all-cause mortality. So this is death rates from any cause of death. And here we're looking at a slightly different time period. We were able to get more recent data and look at between 2016 and 2018. So what this is showing is for the US, the average or the all-cause mortality rate is 759 deaths per 100,000. If you look at it across cities, you see a very similar pattern to what you saw for life expectancy. They're very closely related, so this is what you'd expect. Here, Baltimore has the highest level of mortality, so the worst outcome at 993 per 100,000. And all the way down at the bottom, you see those California cities of San Jose and San Francisco that have mortality rates below 550. We were able then to look at change over time over the past decade. So we're looking at the average annual percent change. So how much the life expectancy or the mortality rate changed each year over that decade. And you can see at the top, the US had a very small change. It was actually not statistically significant. So what that meant was over the last decade, mortality in the US did not change. So as you're probably aware, over time, since we started keeping records, mortality rates have had a pretty serious decline consistently until just recently when we've heard about the life expectancy where it began to stall and then even reduce in the last few years. So what this is showing is over a decade, that's resulted in no improvement, no statistically significant improvement in mortality for the US. If you look for the cities, to orient you to this figure, the darker colors show a statistically significant change. So the navy bars at the top are showing cities who made significant improvements in mortality rates by decreasing their mortality rates over this decade. At the bottom, you see 3 cities that went in the opposite direction. So they had significant increases in mortality rates over the decade each year. So Indianapolis, Louisville, and Houston. So those were the all-cause mortality rates. Now let's look at the difference between blacks and whites. So as Nausea had mentioned earlier, we often use rate ratios. This is a relative measure of inequity. So this is the black mortality rate divided by the white mortality rate, or vice versa, sorry. And so what this means is in the United States, the black mortality rate is 1.24 times higher than the white mortality rate, or the black rate is 24% higher. If you look across cities, you can see the huge variation. At the top, Washington, D.C. is again notable, where the Black mortality rate is 2.32 times higher than the white rate. In San Francisco and Los Angeles, it's also, the Black rate is almost 2 times as high as the white rate. Down at the bottom, you can see El Paso. During this time period, there was actually not a significant difference between the white and Black rates. And in some of the other cities, Jacksonville, Boston, Columbus, there are very small differences between the Black and white rates. Then we looked at how do these levels of racial inequity change over time. So for the US, you see -0.5. That's the annual percent change in the rate ratio. So that means in the US, the racial gap is getting smaller over this decade. When we look at it across cities, we see, unfortunately, only 2 cities. The cities at the top in blue, Memphis and Philadelphia, those were the only 2 that had a significant decline in that racial gap over the past decade. Remember, the light blue and the light orange mean it's not a statistically significant change. But at the bottom, the dark orange, those 5 cities, San Francisco, Seattle, Chicago, DC, and Portland, they all had significant increases in the rate ratios over this decade. So if you look at the size of those increases, they're also substantial. So Portland had over a 3% annual increase or percent change each year over that decade. Okay, and then finally, I just wanted to share annual excess Black deaths. As Nausea said, this is the excess deaths that would not have occurred in the Black population if their mortality rate was equal to the white rate. So it's a function of both the difference between the Black and white rates and the size of the Black population. When you look at excess Black deaths, 2 really stand out, 2 cities, right? Chicago and New York. Both have over 3,500 excess Black deaths each year because of that racial inequity. Many cities have big gaps of 1,000 or 2,000 excess Black deaths, but a lot have a much smaller number. So at the very bottom, you see San Jose with only 58 excess Black deaths. So the Chicago number is really striking and hits close to home. And I also want to point out, we did this study over 10 years ago. This is the headline from the Chicago Sun-Times back in 2009 from the work we did 11 or 12 years ago, where they found 3,200 excess Black deaths. And now we have 3,800. So as the change analysis showed, we're moving in the wrong direction here in Chicago. Okay, with that fairly depressing presentation and data, I'm going to turn it over to Fernando.
Thank you, Maureen. And I don't know about others, but for me, the presentation is not depressing, right? It's alarming, energizing, provokes anger in all the right ways. And really, before I say anything else, Maureen, I want to acknowledge your leadership in this project and the great welcome you gave me at SUHI when I was a visiting fellow a couple years ago now. And your remarkable work holding this project together, right? I was struck by, I think it was slide 3. So many people have pitched into this project, and you've been the heart of it. So I want to acknowledge that in particular, as well as Nausea and Abigail and all of the remarkable people who have contributed to the work. So I think in my remarks, I want to explore some of the city level work that features in chapter 6 of the book, where we tried to do some relatively simple analyses to look at predictors of some of these outcomes. And very much knowing that this is both a continuation of the work that SUHI has been doing for a long time, and also a starting point for even deeper work that we can work on together in the coming years. Everyone knows I try to emphasize often when I present how important the work of Paul Farmer has been in my thinking around health inequities. And Farmer gives us a very simple model that's kind of embedded within this book, right? Of geographically broad analysis, that to understand any one particular place, you need to be able to compare it to other places. And also the idea of a historically deep analysis. And SUHI has been also championing that idea for a long time, right? That to understand the health of people in North Lawndale today, we need to understand the history of North Lawndale over decades and generations. And the same thing applies here when we look across cities. We're trying to understand the mortality outcomes, both in overall levels and levels of inequities. And we need to understand the deep structural roots that have shaped those patterns over generations. So this is one of the models that we featured in the book. This is in chapter 2 in particular, where we borrowed many ideas from Nancy Krieger and others. We first contrasted traditional individual or behavioral lifestyle models that really place the blame on the individuals. And we contrasted that with alternatives from public health and social epidemiology. Models like this one from the Bay Area Regional Health Inequities Initiative, we found great value in, right? Because they center our gaze on the underlying systems of power and oppression. They acknowledge the importance of the social determinants of health, but they urge us to go even further upstream, right, to the structural drivers of health inequities. To be sure, we don't have a statistical model for each of the arrows in this graph, and I'm not even sure if that would be possible or even helpful. The point always is that context really matters, right? The specifics will vary from city to city. But the usefulness of thinking of our outcomes from a model like this rests not on any particular predictive capacity or any one hypothesis that we can test, but more in the overall approach we can bring to the data, looking always to understand the context and the structural drivers that shape mortality outcomes and inequities in those outcomes. So for me, this brings up the dual nature of the title of the book, Unequal Cities. We've seen so far the inequities and the outcomes in the mortality rates and life expectancy. But we also want to acknowledge that our cities are unequal in another sense, right? In these structural and social determinants, which manifest in different rates of poverty, segregation, and income distribution. Next slide, please. Thank you. And one more. Yeah. So a word of caution, right? Like there is no one magic answer. There's no one variable that we can ever identify that perfectly explains the patterns that Maureen so eloquently walked us through. Our strategy, though, rather than looking for one perfect answer, was to cast a fairly broad range, a wide net, right, across key cornerstone variables like poverty and median household income, measures of income inequality that we know from previous research will matter, at least to some outcomes. And there we use two indicators, the Gini coefficient and the index of concentration of the extremes for income, which tries to quantify the concentration of both poverty and affluence in any particular city. Two measures of racial segregation, the widely used index of isolation, and also this relatively newer index of concentration of the extremes, which can kind of quantify the concentration of Blacks versus whites, and can also be used to quantify racialized economic segregation, so the joint effects of both race and income polarization. And we also accounted for population size and racial composition. Next slide, please. Thank you. So first, important to acknowledge the variability, right? The huge levels of differences that exist within our big cities. So we see differences in their outcomes, and we also see differences in their structure and social conditions. And we can see that just with contrasting poverty rates, right? From a low of 12% to a high of 39%. We see the same thing with median household income and with percentage without a high school diploma. Next slide. We see similar levels of variability with our indicators of racial composition and racial segregation. If we look at the population proportion that is non-Hispanic Black, from a low of 3% in El Paso to a high of 81 in Detroit. And one more quick. And we see similar variability with our measures of income distribution, with Gini values ranging from 0.46 to 0.55 on a scale that ranges from 0 to 1, indicating substantial variability, even if our low end are still relatively high in terms of international comparisons, right? Even our most equal city in terms of income distribution fares poorly in comparison to cities in Europe or Canada. Next slide. Much of chapter 6 then explores relatively simple associations. So it's not a fancy statistical model. Our approach here was simple and straightforward, to find descriptive associations between each of the city level characteristics in our measures of mortality. Always the total rate, the Black rate, the white rate, and the Black-white rate difference as a measure of the absolute size of the gap between the two populations. So I'll walk you through a couple of the correlations to give you a sense of what that part of the book looks like. So we'll begin with this correlation of negative 0.079, which is really high by most standards in the social sciences. And it's the correlation between total all-cause mortality and the ICE index for income. Next slide. So this is what the correlation looks like. For ICE income, low numbers, negative numbers indicate the concentration of poverty in any city, and high numbers indicate the concentration of affluence. Right? And the association is quite high, as high as we see anywhere else in the social sciences. And of course, not unexpected, right? But I want to emphasize that there's nothing natural or inevitable about this. This is what health inequities look like. This is what health injustice looks like. The ability to live long and healthy lives is so structured or determined by the characteristics of the places in which we live. And those characteristics, that polarization of income, is the result of public policy. ICE income is not only associated with total all-cause mortality on the left, but also with the inequities in all-cause mortality depicted on the right. So there's a bit more noise in that scatter plot. The association is not as strong with more unexplained variability. So there's a bit more noise, but for me, the signal is clear, right? Inequities in income mirror inequities in mortality. Of course, this isn't the type of analysis that can prove causality, but the flow is clear, right? And a sign of how upstream characteristics like the distribution of income affect the health of populations. Next slide, please. Thank you. Similar findings are presented in this chapter between the Gini coefficient, another popular measure of income inequality. The higher the number, the more unequal the place, and the life expectancy difference. Cities with more inequality in income have larger life expectancy gaps. Right? So there's, again, that dual nature of inequality in both our determinants and in our outcomes. For us, all of this generates new questions, right, that we are eager to explore, particularly around context, local politics, local policies, history, how it can incorporate lagged effects. So again, our health is influenced not just by the characteristics of our places now, but generations, decades worth of public policy. So what's the effect of income inequality 10, 20, 40 years ago on the health of people today? That's mostly an unexplored question. It really is an unexplored question at the level of cities in this comparative way. And I'm eager to continue that work in the coming months and years. Next slide. Lastly, a few data points on local policies, which are also featured to a smaller extent in Chapter 6. We took advantage of a great report card, a great scorecard from the de Beaumont Foundation and Kaiser Permanente, which assessed each city's health-related policies, including evidence policies such as inclusionary zoning regulations that boost affordable housing stock, anti-tobacco policies, and universal access to kindergarten. What we see in Chicago is a clear outlier. We have enacted some great policies, but clearly have generations worth of structural violence to overcome. It shows up in many of our analyses. Next slide. And even across the United States, the cities with gold star rankings, right, they're passing the right kind of legislation, have deep and substantial inequities, shown here with the all-cause mortality rate independently for Blacks and whites. Right? The difference between the blue boxes and the pink boxes is profound, right, at all levels of policy score, even amongst our cities that are passing the right kinds of legislations. So the goal of all of this work is of course not just to produce more charts and more tables, or even just publish another book. The goal is to contribute to a movement, which I think has been discussed and featured throughout the day's conference. It's to work in collaboration with others with the goal of making the world a fairer place. And with that, I'll turn it over to our good friend and colleague, Nick Prashant from the Chicago Department of Public Health to tell us about the work on that side.
Thanks, everybody. Again, thanks again, Maureen, for inviting CDPH to this conversation. SUHI has been a great partner. I just want to start my talk just by, bringing up my sort of personal connection to Steve Whitman and the early days of SUHI and even pre-SUHI. When I was in grad school in the mid-1990s, I was fortunate enough to sort of be starting my public health career right at the time that the heat wave struck Chicago in 1995. I was recruited onto a volunteer team of students who was helping the CDC understand some of the underlying causes of mortality of folks who succumbed to the heat wave and those who didn't. And through the project, I was fortunate enough to meet Steve, who at the time was the director of epidemiology for the Chicago Department of Public Health, the seat that I sit in now. But I'm actually at my house, but you know what I mean. So there's kind of a really interesting kind of bookends to my career, starting my public health career, meeting Steve and being influenced by his words around he was a city director, but not trusting the city's numbers in terms of the reporting. This is the first time I had heard kind of racism called out as an underlying cause of this, unnatural phenomenon that had, taken the lives of over 1,000 Chicagoans. And really kind of, he really sort of influenced my thinking around sort of the social constructs that lead to poor health outcomes. At the time I was working in HIV and working with injection drug users. So the lessons learned were, kind of lifelong, and I've carried them to this day. So I guess you go to the next slide. So, from that time point to 2020, when the city of Chicago developed their latest version of the health improvement plan that we are sort of required to do as part of our accreditation. This is the plan that we released in last year with the help of SUHI and other partners. But really kind of framing the goal of reducing the gap in life expectancy between Blacks and whites in Chicago. So I'll sort of talk about how the journey that sort of brought us to making that central metric, kind of the part of the integral part of the framework of this plan. Next slide. So going back to 2014, which is the year that I started in Steve's old role, we first launched Healthy Chicago 2.0, which was the previous version of the health improvement plan, in which we, kind of, formalized and, kind of put into stone this idea that changing community conditions would influence and help people gain better health outcomes. So, this was an important step forward in terms of thinking about public health rather than looking at individual level interventions, but rather system level interventions. But the plan didn't go far enough to actually propose ways of actually changing those community conditions. It sort of took the important step of recognizing those community conditions that needed to be improved. So, as part of this plan, increasing life expectancy was an overarching goal, kind of a generic general goal to, see sort of modest improvement in life expectancy over the course of the plan based on, strategies that were developed to promote and enhance individual and neighborhood level interventions. So fast forward 5 years, next slide. And as we were preparing our work to release an update to the 5-year plan, so another 5-year plan, the Healthy Chicago 2025 plan, we started, updating our metrics and taking a look at our quantitative progress on the previous plan. And we're surprised to find that there was actually a decrease in life expectancy in Chicago just prior to the 2020 year. So we were surprised to kind of see this decline, not only in the face of kind of start of a Healthy Chicago movement, but also just kind of thinking about, not expecting a decline in life expectancy in industrialized, wealthy countries. It seemed very counterintuitive to us. So we dug into the life expectancy metric. And what we found was that there was a vast gap by race ethnicity. So ultimately, we sort of focused on this 8.8-year gap between Blacks and whites in Chicago. So that was a sort of a staggering number that we, really focused on and began socializing as, an important, focus of the development of a new plan, was to really focus on this 8.8-year gap, which we found to be completely unacceptable and much larger than we had expected. And we took a deeper dive into that gap, and we conducted a decomposition analysis. A former colleague, Emily Laflamme, who I'm sure you will be hearing more about life expectancy work that she will be doing in her new role at the AMA with Fernando. But we, she was integral into the sort of developing this decomposition analysis, in which we identified, some factors that were driving that 8.8-year gap. So what were the underlying causes of death that were contributing to that gap? So we found that chronic disease made up about 50% of that gap in life expectancy. Homicide made up about 25%. And then infant mortality, infectious disease, HIV deaths, and opioid overdose, fatal opioid overdoses made up sort of the great remainder of that gap. So we were left with these very discrete outcomes to focus on for a new plan. And, the way we decided to, to address them is we, just like the way we decompose the gap between life expectancy, we also sort of decomposed the community conditions that, we sort of felt led to these outcomes, things like improving mental health, healthy parent and baby interventions, violence prevention, drug use prevention. We wanted to, kind of decompose those, and we decided to sort of focus on the structural and systemic factors that contributed to the community conditions that led to these poor outcomes. So if you look at sort of the roots of the tree on this slide, you can see the idea being trying to promote anti-racist systems and multicultural kind of approaches to organizational development, government accountability, economic opportunity, and of course, fair laws and criminal justice. So we had sort of launched this plan with this sort of framework around the gap in life expectancy, which led us to sort of setting up a plan that really focused on these upstream causes. Next slide. So we launched the Healthy Chicago 2025 plan right at the beginning of the COVID pandemic, and I can't do a presentation these days without talking about COVID. So I apologize for that if people are tired of hearing about it. But once COVID came on the scene, we were quickly aware of the racial disparity. This is sort of just looking at the first couple of months of death rates by race ethnicity. And you can see the vast difference between the purple line, which is Black Chicagoans, the blue line, which is Latinx Chicagoans, and the red line, which is white Chicagoans. So we saw this as a perfect opportunity to sort of apply our lessons and really kind of make this really the first step in launching and implementing the values and actions that this plan proposed. So, we saw immediately that over 70% of deaths, 70% of deaths were occurring among Black and Latinx Chicagoans. So over the course of 2020, we saw about 3,200 deaths among Black and Latinx Chicagoans. And if you think about the approximately 12,000 Black and Latinx Chicagoans who die every year, that represents about 25% of the accumulated mortality over 1 year. If you kind of put that in perspective, the leading cause of death is coronary heart disease, of course, and that we saw about 4,200 of those deaths among Black and Latinx Chicagoans in 2019. So we really anticipate that COVID is going to be, quantitatively among the leading cause of death, and probably the leading cause of death in particular age subgroups among Black and Latinx Chicagoans. And a practical intervention to stave off death from COVID-19 was a robust vaccination campaign. So next slide. So the vaccination campaign that we have embarked on just recently is, the framework of the campaign is rooted in the by the quantitatively understanding the vulnerability in community areas of Chicago. So we developed a Chicago COVID vulnerability index that combined COVID outcome data with specific risk factors specific to COVID, like mobility and crowded housing and occupations in frontline worker status. And then, of course, other sociodemographic factors that are associated with vulnerability in general. And we were able to sort of develop this index and apply different scores to across the community. And we have used this framework as to develop the prioritization of vaccine allocation in order to sort of stave off death in the communities that have borne the brunt of the COVID outbreak, as well as communities that we anticipated having low vaccine uptake. So very sort of rooting mortality, rooting this data into action for sort of this crisis at hand. Next slide. So what are the greatest opportunities overall in improving Chicago's mortality gaps? I think, the use of data, the data that we, have seen SUHI and DePaul University and other entities generate and sort of help us understand more deeply the relationship between excess mortality and racial inequity and racism in Chicago. Next slide. And this is an effort that can't be done with hundreds of partners across many different areas: healthcare, business, social services, government agencies, and of course academia. SUHI being a very important partner in every step of the way. Next slide. And so how do we actually reduce? What is our best chance is really sort of to follow the Healthy Chicago 2025 way. So picking the right priority areas: housing, food access, environment, public safety, neighborhood planning, health and human services, focusing on the right populations, having some goals for those populations, and really kind of framing this all in very systemic and community-based work to transform not just the community conditions, but the policies and processes that create those community conditions, whether it's city government, federal government, or business and other organizations in the city. Next slide. So, I think the other way of, really addressing mortality gaps is really leveraging the assets in every neighborhood. So aside from the policies and processes, this is a sort of a schematic of two community areas, West and East Garfield Park, amongst the poorest areas of the city, amongst the most representative of the worst health outcomes, some of the largest, lowest life expectancies in the city. But yet, if you were sort of an alien, floating above the world, trying to find a place to live, you looking at this map, this is a representation of the assets in the community, things like playgrounds, schools, train stations, bus routes, divvy stations, parks, athletic fields. And you take a community of 35,000 and you look at this map, and it looks pretty darn good in terms of the assets that are available in this community. So what is the gap between the leveraging these assets to actually work for the people in this community? If these assets were leveraged in the right way and made available to the people in the way they needed it, we likely could see better health outcomes in general, because it could improve their life in many ways. Next slide. So just a kind of a concrete example to close my talk. There's a famous Chicago artist, Carrie James Marshall, who painted this painting. I love this painting. It's called Knowledge and Wonder. And it was painted as commissioned by the Chicago Public Library System for installation in the West Garfield Park Legler Library. So there it sat for about 25 years, kind of unassuming, part of the kids section of the library. And in 2018, the city of Chicago had this not so bright idea to remove the painting from the library and leverage the recent fame that the artist had achieved to sell this painting and renovate the library using the proceeds. It was estimated that the painting could have fetched $10 million at auction. It was actually removed from the library, sent to Christie's, to the auction house, and at the last minute, the sale was pulled based on some community feedback, and kind of the community had been outraged that this great asset in their community that belonged to their community, that represented their community and the hopes of their community so well, was being used to sort of, they had to pay the price for the renovation of this library. So the idea is to identify and recognize the assets in our community, whether they're human or physical or capital assets, and leverage them for the good of the people. So data is just one of those great assets that we can all use together to do this. So that's my talk for now. Thanks.
Thank you so much, Nick. It's really helpful to have your reflections on the data and what cities can do next. And it's really helpful to see the great work that CDPH is doing in Chicago. And presumably this will result in narrowing that gap the next time we do this type of analysis. Okay, I just wanted to conclude our part of the conversation before we go to Q&A with another quote from Steve Whitman. He said this in an interview. He said, "We have to regard this problem of racial inequity as if it was a problem in our family, and we have to fight like hell to change it." So this is our ask of you all. This is hopefully you've been motivated by this data and you'll join us in this fight for equity. Now it looks like we have time for some questions from the audience. Stephanie will be moderating from the chat. Feel free to put some in there.
Yes, thank you, Maureen. If anybody has any questions that would like to be addressed to by any specific presenter, please also let us know. One of the questions that did come up during the presentation was, how would that excess Black mortality data look if the data were presented by regions? Would we be likely to see the greatest numbers in the Southeast, where the African-American population is more concentrated?
Thanks for that question. I think Abigail Silver, our collaborator on this work, had answered in the chat. She had agreed that yes, we would probably expect to see that. We haven't done the analysis by region, but because excess deaths is a product of both the size of the Black population and the relative difference between the Black and white populations, there would be more excess deaths in places that had larger Black populations, assuming they had a racial inequity there.
We don't see any additional questions in the chat at the moment, but if folks are willing to ask anything else, please feel free to add it to the chat once again. We'll give it a, oh, here we go. This question is for Nick. Can you please tell us more about the Health Chicago report and the action the city expects to take?
Sure. So the Healthy Chicago 2025, the latest version, it was published last year at the at the beginning of the COVID pandemic, the first half of the year. It's available obviously on our website, and you can certainly peruse it. There are a whole host of strategies and action plans developed to move forward. We have identified, our partners in the plan have sort of stepped up to become kind of leaders of different action items in the plan to address the the priority areas that I presented in one of my slides. So there's a whole host of strategies that we could probably spend an hour kind of discussing, but I would certainly encourage folks to get a hold of the plan. We can certainly distribute the plan through this group somehow, and make it available. But we have like I said, is sort of launched at the beginning of the COVID pandemic. So, much of our priorities at the health department has shifted to COVID response. It has given us a great platform to apply some of these principles that we've developed. So, we really haven't gotten a chance to really sort of dig into all the other partnerships that we've developed to go forward, being sort of mired in this COVID response. But, I do expect there to be soon a report issued called the State of Black Health, that's going to sort of outline some of the major challenges facing Black Chicago and some of the health disparities that Fernando and others have outlined earlier today. But certainly, that's going to be sort of a call to action, and I would look for that to sort of be released in the next probably 2 months. And we're looking for sort of, a call to action at that time to really kind of dig in and start addressing the issues and strategies that have been identified and planned as part of the Healthy Chicago 2025.
Thank you, Nick. Another question that we have is, what are some of the challenges to extending the disparity analysis to other races and ethnicities?
Yeah, if I can pitch in on that one, it's a really thoughtful question, and we're mindful and appreciative of the critique of not normalizing white and whiteness as the reference group in all analyses. That's a huge issue, we're also mindful and appreciative of the concern of data invisibility, right? That other groups also need to be documented in this way. Also looking for variability within these very coarse categories, right? This for us is really just a starting point. It's a very blunt measure, very blunt categorization that we think sheds light on in broad patterns of inequities, but finer grained analyses looking at particular race ethnic groups and the variability within them as well is also vitally needed.
And another question we have is, what is the role of community feedback in designing, implementing, and assessing interventions to address inequities and mortality, etc.?
Nick, do you want to speak to what CDPA chooses the process?
Sorry, I was actually typing in the link. Can you please repeat the question?
For sure. The question was, what is the role of community feedback in designing, implementing, and assessing interventions to address inequities and mortality, etc.?
Yeah, I think that's a great question. Community, authentic community engagement is key to developing any health or other community-based intervention. Certainly, I think we are moving closer to a model where, we have formalized kind of partnerships and mechanisms to elicit community feedback. The Lightfoot administration has, embarked on some pretty ambitious citywide anti-poverty agenda kinds of interventions, with a stated goal of, reducing, racial inequities in many different areas. So, I think as far as we got with that plan prior to COVID was, a series of very robust town halls that have been held in every, region of the city, trying to be very mindful of all the different, the diversity and all the different groups and voices that need to be at the table. So I think that's, that's certainly, a formalized role in, community engagement, and the city is looking to utilize the same community engagement model for, not just for health improvement, but, like the Department of Planning and Development, Department of Transportation, they're all sort of trying to adopt this community engagement model to, in doing their work. And a lot of that has been driven by sort of this health in all policies approach, and sort of health department has been really leading in developing ways to engage the community.
Thank you so much, everyone, for your engagement.